Assalamualaikum and hello guys, welcome to Carnation Space. So if you remember, we are covering about management of breast cancer, CPG 2010. So let's continue from where we left off. We are number 5, staging. Okay, so staging is revised by the AJCC, American Joint Committee of Cancer. So there are staging for early breast and also advanced breast. So regarding early breast cancer, meaning it is not spread beyond the breast or any axillary lymph node. So this includes DCIS, ductal carcinoma in situ, stage 1, 2A, and 2B. So regarding for screening for metastasis, do we need to do or not in early breast cancer? That's a question, right? This one. It says here that whatever either chest X-ray, ultrasound, bone scintigraphy are not recommended, okay, for asymptomatic in early breast cancer T1, T2 with nodal node or nodal 0 or 1. And then because why? Because if we do at the early breast cancer, it only poses low diagnostic. Okay, low diagnostic yields. Okay, but we do only when the symptoms, whether it's lung symptoms, palpable liver, abnormal liver function, or bony tenderness, then we will do. And if you look at here, we have here FDG PET, fluorodeoxyglucose positron emission tomography. So this one is serve as confirmatory test. Okay, it's not routinely done. And also why we didn't do for early breast cancer can, because it says here bone scan, if we do, it has very high false positive value, about 12%. Okay, we don't want to take that risk. So at the end of the day, what I'm trying to say is early asymptomatic operable, we not routinely done the screening for metastasis. And if it suppose a patient have symptoms and suggestive of bone metastasis, we do bone scintigraphy. Okay, if CT thorax are negative. Okay, regarding staging of the advanced breast cancer, we have LABC, locally advanced breast cancer, meaning whether the size is more than 5 cm or involving of the skin and chest wall, and also involving of lymph node regional. This one for advanced, they are stage 3A, 3B, and 3C. Okay, so to assess the extent of the disease, we must do bony and visceral extent of disease to bony and visceral metastasis. We must do the radiography, ultrasound, bone scintigraphy, CT, MRI, positron emission, paired with CT scan. Okay. If we I also want to highlight here, whole body MRI is actually better than the PET scan to detect the distant metastasis. This one is also the same, trying to say here, meaning we need to do further imaging. And then if we want to look for axial metastasis, we do the CT with bone window and bone scintigraphy. And if we want to see the metastasis to extremity, we do the scintigraphy or plain radiology. Okay, regarding this positron emission tomography, it says here, what it's trying to say here is that PET scan must accompany with CT. Okay, why do we do it? Because we need to know the physiology of malignant tumor. They have higher glucose metabolism, so that's why it take up more FDG, fluorodeoxyglucose, this one. Okay, although it says here, what did I say? A PET scan is accompanied by CT scan, right? Okay, but it's not diagnostic for metastatic disease. Okay, it's not diagnostic. Besides, it's cost effective. Okay, in medicine everything is very expensive, so that's why. Okay, for PET and CT scan, it's a accurate imaging modality. It's superior to CT scan for the diagnosis of tumor recurrence. What it says up here is that it's not for metastatic, not diagnosis of metastatic, but it is for diagnostic of recurrence. Okay. Sounds like the same, but it's not the same. Okay, and then we do this PET scan and CT scan used in whose imaging is suspicious. Okay, for FNAC and core biopsy scan, for this patient, which one do we want to use? Whether we want to use FNAC or we want to use core biopsy. So here's the answer to that. So there are studies, number of studies done, and some finds FNAC better, some finds core biopsy better. So Malaysia said, what Malaysia said? Malaysia said FNAC is initial method of pathological assessment of palpable breast lump if the expertise available. And how about core biopsy? Core biopsy is complement if the FNAC is equivocal. And in fact, we can actually do both if the expertise are available. Okay, so always remember FNAC is the initial method, not the core biopsy. Okay, you also have heard HER2, right? HER2, human epidermal growth factor receptor 2. So this HER2 testing, there are a lot of methods we want to test for HER2. There are fish, shish, okay? So what is the best one? So for Malaysia, we use everything: fish, fluorescent in situ hybridization, silver enhanced in situ, used for confirmation when the immunohistochemistry is 2+ or 3+. Okay. So this one, I don't know if this is important or not. Reporting, yeah, important lah kan. Okay, reporting. How do we report? We must insert the location, the type, the grade, the lymph node involvement, resection margin, infovascular invasion, breast changes, and their receptor, hormone receptor status, and HER2 assessment. Okay, now treatment. No guys, I will stop here. We will continue the treatment in another video because it will be lengthy later. So thank you guys for listening. I'll see you guys very soon. Bye.